Ladies and gentlemen, boys and girls, welcome to Healing Outside the Box. My name is Jean Tiberio, and today I'm bringing you episode 276, The Harmful Effects of Fat Shaming on Obesity Rates. Now, I just want to mention before I begin, what a lovely day I had this afternoon at the farmer's market. I took full advantage of the Healthy Incentives Program, or HIP, which is going gangbusters in Massachusetts. And I'd like to remind you all that it's a federal program. Hopefully your state is participating. Basically, I get $40 worth of free produce every month. The state actually provides the incentive for farmers to belong to this HIP program. So it's win-win all around. I was just sitting there at the farmer's market, enjoying the perfect 74-degree sunshine, listening to the live music, and thinking, it just doesn't get better than this. And then it did. A woman walked up from behind and said, "I'd like to buy you some flowers." And I said to her, "Well, you just made my day." Everyone there was in a good mood. They were walking children and dogs, and I went home with a bag full of free produce. So you may want to check out the farmer's market in your town, and hopefully there is one. This is peak season for a lot of great stuff. Okay, like I said, I'm calling this episode The Harmful Effects of Fat Shaming on Obesity Rates, and it's a two-parter. Now, over the years, I've been a registered dietitian, a nutritionist in private practice, and a health and wellness coach. In addition to all those labels, I've had 6 years of college courses to tell me what should be common sense by now. My years of book learning taught me nothing about eating behavior. Or should I say, my years of book learning taught me nothing. But I've learned from a bunch of people that I've worked with over the years. For example, calories in should equal calories out, or calories burned. It doesn't. In a deficit of 3,500 calories should equal a pound of weight loss. But not so fast, because as it turns out, that's not true either. Okay, so first of all, calories in, calories out doesn't work. That is because it all depends on the composition of your body, the composition of the food, your age, and your blood chemistry. Also, more muscle equals more calories burned at rest. So relying on weight doesn't work. So it can't estimate how many calories you burn. And muscle is denser than fat. In other words, there's more weight per unit of space. A 250-pound athlete will burn a lot more than a 250-pound couch potato. A person that is high-strung with lots of stress hormones will burn more calories at rest than a calm person. And a person that is very overweight may conserve calories because doing certain activities is going to be more strenuous. For example, they may use one arm instead of two arms to grab something. A person sick with a fever will burn a lot more calories than a healthy one. In fact, 7% more for each degree of body temperature. And that's a lot. This is also true of someone exposed to cold temperatures without sufficient clothing. It costs you calories to shiver, in other words. So a straight-out comparison isn't fair. We can estimate, but it won't be accurate. It's simply harder to lose weight if someone is older, slower, smaller, and calmer. So a deficit of 3,500 calories leading to a pound of weight loss cannot apply to everyone equally. Also, the way a dietitian estimates how many calories a person needs is based on height, weight, and age. We plug those figures into a mathematical equation and get what we call a basal metabolic rate, or BMR. Then we multiply that by an activity factor, 1.2, 1.5, 1.75. But those estimates are based on an equation that is not factored in all of the things that I just mentioned. So it's not accurate. And we haven't even discussed the role hormones play in all of this. or class distinctions, or food deserts. There are books written on this one subject, so I'll just put the mathematical calculations in the show notes and move on. Today, I want to talk about the negative effects of weight shaming. As it turns out, shaming campaigns work for smoking, but not weight loss. The reasons are pretty complicated, not the least of which food is absolutely necessary for our survival. No, I'm not going to pretend to know all the answers. I do know that shaming someone at a delicate young age can lead to eating disorders like anorexia nervosa. That's a serious illness, which sometimes carries a 10% fatality rate. So I don't know all the answers, or maybe any of the answers, but a few recent articles bring up some interesting questions. A recent study listed the best and worst states for, as they put it, being in shape. They got this from the CDC data, apparently. They examined rates of obesity, diabetes, heart disease, number of medical checkups, and the number of gyms in the area, an indication of the relative importance of fitness. The 5 states in the best shape are DC, Massachusetts, Colorado, Connecticut, and New Hampshire. The 5 states in the worst shape are Mississippi, West Virginia, Arkansas, Kentucky, and Alabama. Most of the 10 best were in the Northeast, and 9 out of the 10 worst were in the South. That data should surprise no one, and there are many reasons for that. Access to healthy food, social pressure, and psychosocial issues are a few. The more difficult conversation is around how to fix this seemingly insurmountable problem. A recent video by Dr. Michael Gregor discussed a 4-year study on the long-term effects of weight discrimination. It seems that the stress of being discriminated against turned into a vicious cycle of dieting and gaining weight. I'll give you the link to this 6-minute video in the show notes. Over the 4 years, the study showed that those who felt as if they were discriminated against were much more likely to stay overweight than those who didn't feel the stigma. People who felt weight stigma at fitness clubs were more likely to avoid exercise. No one wants to be shamed, which feels like a no-brainer to me. There's also obesity-related depression. And what do we feel like doing when we're depressed? Yes, you guessed it, ice cream. There's also stress-induced rises in cortisol levels, and that causes higher levels of inflammation and oxidative stress. And over the long term, that can contribute to heart disease and diabetes. So the bottom line is that a shaming campaign for overweight folks makes matters worse. Here are some more study results. People watched a video that was meant to create a stigma against overweight individuals. After watching the video, normal weight people ate about the same amount of food. But when overweight people watched the video, watching other overweight people being shamed caused them to eat more. Here is a quote from the study that Dr. Gregor cited. Open quote, "If shaming worked, there would be no overweight people." Close quote. Well, duh. So what group of people actually think that shaming people into losing weight should work? Well, physicians. Maybe because it worked with smoking, but it doesn't work with weight loss. Can I say that enough? I don't think so. In another study, more than half, or 54% of physicians, said they'd spend more time working with patients on weight management issues if the time was reimbursed appropriately. What? These people don't get enough to make ends meet? That is the problem right there. The medical association doesn't think it's their job to get involved because nutrition, after all, is a ladies' issue. In the 1980s, because nutrition was a ladies' issue and not respected in the medical community, dietitians were not even reimbursed by insurance companies. That means we were mixed in with the cleaning staff and security guards. No respect equals no priority. Dietitians with master's degrees were getting paid about $10 an hour and forced to pay for their own continuing education credits. I was joking with my personal physician about how I was paying more than he was. Even he was shocked to hear how little dietitians get and how little respect they receive. Somewhere in my podcast episodes, I talked about the story of going to a conference for registered dietitians. There were more than 500 people in a huge conference room, and I could not find one single man. In some of those conferences, they turned the men's rooms into women's rooms and just allowed the women into the men's rooms, since there were no men. I kid you not. There was a handwritten note that said WO in front of the men's room sign. Anyway, still another study with unfortunately only 47 participants were asked this question. Before your weight loss surgery, how badly did you want to lose the weight? It was asked in this way. If someone were to offer you $2 million to stay morbidly obese forever, would you choose the money? Or would you have chosen to be normal weight no matter what? Here were their three choices. Number 1, I would have chosen no money and being normal weight. It would have taken me no time to decide. Number 2, I probably would have chosen being normal weight, but I'd have to think about it for a while. $2 million is a lot of money. Number 3, I want to be normal weight, but I could really use the money. If I could be a multimillionaire, I could live with being morbidly obese. I would take the money. Here are the results. 46 out of the 47 people chose number 1. One person chose number 2, and no one chose to take the money and remain obese. Another shocking part of this study went like this. The 47 people were then asked if they wanted to switch to another disability. Normally, people want to stay with their own disabling condition rather than try to cope with something new. I can vouch for that, and I've been in a wheelchair for 30 years. But when it came to obesity, just the opposite occurred. All 47, or 100%, would rather be deaf than fat, and 90% would rather be blind for life than fat. This is an article from the AMA Journal of Ethics. Oh, I'm giving you a quote. This is from the American Medical Association. Quote, despite the fact that the majority of Americans are now medically defined as overweight, stigma against individuals who are obese remains a widespread phenomenon. The reported incidence of weight discrimination has increased by 66% since 1995 and is now on par with rates of racial discrimination, especially among overweight women. Unfortunately, healthcare professionals are not immune to this. Even those specializing in the field of obesity have been shown to both endorse and display weight bias at an alarming frequency. In fact, one study that investigated attitudes towards individuals who were obese and presumed to be seeking medical care found that physicians viewed patients who were obese as less disciplined and more annoying, and reported less desire to help them than to help thinner patients. End quote. That is one heck of a run-on sentence. I think medical students need to take more English Lit and nutrition. Here is another quote. Quote, for example, studies have shown that medical students believe that patients who are obese lack self-control, are less likely to adhere to treatment, and are more sloppy, unsuccessful, and unpleasant than thinner patients. In one study, medical students reported that patients who were morbidly obese were the most common target of derogatory humor among attending physicians, as well as residents and students. In another study, 24% of nurses reported that they felt repulsed by patients who were obese, and 12% reported that they did not want to touch these patients. While another study found that 31% to 42% of nurses indicated that they would prefer not to treat patients who are obese. End quote. Here is something else. In general, obesity rates are increasing, but thin people, for the most part, are not getting overweight. So why is that? Nobody knows for sure, but there are lots of contributing factors. They are insulin sensitivity, leptin, calories burned with white-collar versus blue-collar jobs, epigenetics, refrigerators, or an overabundance of available food, lack of sleep, industrial food composition, inner city stress, leading to increased cortisol levels, depression, time spent in front of TV, presumably with food ads, more cars and less walking, increased anxiety, income inequality, and reduced infectious disease. In other words, fever burns more calories, as do open sores and parasites. Oh, by the way, leptin is a hormone in your brain that helps you regulate your body fat and weight. If you lose weight too fast on, say, a severely restrictive diet, leptin levels decrease, and that makes your brain think that it's starving. I'll put the article from the Cleveland Clinic on leptin in the show notes. There is an article put out by the NIH that talks about this. Well, I'm sure there's lots, but this is one of them. Stigma is a prevalent problem for people living with obesity, and the evidence for any changes in this phenomenon is mixed. That was a quote, by the way. There is an idea, as I've mentioned, that fat-shaming people with obesity will help those people lose weight. And again, fat-shaming has received a lot of attention in the years since the American Medical Association designated obesity as a disease. Fat-shaming was hardly a blip on the radar before 2012, but interest in this particular subject has grown dramatically, as have people's opinions on the subject. You can probably hear in my voice that I'm not a happy camper when this subject comes up. Just the word fat-shaming, as they say, inherently positions explicit bias against people with obesity as socially unacceptable. And that, in my opinion, has a lot to do with what this is really about. I said earlier that shaming seems to work for people to stop smoking. However, there was more stigma around making it difficult for people to stop smoking at work, in restaurants, and even in a baseball stadium. No one told those smokers that they were lazy or unpleasant. In fact, when you imagine people that smoked in the movies, you're thinking James Dean and how cool he looked, or Lauren Bacall and how sexy she looked. It's quite a different story for overweight people. Add that to the fact that our bodies don't need nicotine. We crave nicotine. There's a difference. We'll breathe better after we quit. So we're basically comparing apples to oranges when we compare fat shaming to making a deterrence for smokers to smoke in public. Here's a quote from that NIH article. Quote, "While explicit shaming of people with obesity may be increasingly rejected, it is not clear that the prevalence of weight bias is changing. In fact, research by the Obesity Action Coalition finds increasing social discomfort with people who have obesity." Before I get around to the treatments, or my opinion about suggested treatments, which will unfortunately have to be next week, I need to increase your discomfort level a little more. Decades ago, I came across an article that almost no one read. Again, it was written for lady dietitians, and it went something like this. An estimated 80% of morbidly obese women were sexually abused in childhood or adolescence. That would make obesity the symptom or result, and pedophilia the disease. Ouch. No wonder why male physicians aren't comfortable talking about this. And books could be written about that. I have one more discomforting story before I stop for the day. I was working as a dietitian in the hospital setting, and I had 3 floors of patients that I was assigned to. That's about twice as much as I should have had. I was working the psych ward with a patient who had anorexia nervosa. After months of working with a team of professionals and finally gaining some of the weight back, she was making real progress. Her weight was up to 98 pounds, and she could eat 1/2 of a turkey sandwich for lunch, which was really good news. So one day I went to the floor to check on her, and I was met by her psych nurse. Now, I should say first that both children and adults who suffer from protein-calorie malnutrition can get a bloated stomach or some fluid buildup, because the fluid can accumulate in the belly as a result of the starvation. So anyway, the nurse said, "You're not going to believe this, Jean." We sent her to a hospital physician for an exam. He grabs some flesh on her stomach and pinches it, saying, "You're a little chubby for an anorexic, aren't you?" I just stared with my mouth open. The nurse said, "I wouldn't even go in there if I were you. She's on the floor in a fetal position." So this presumably brilliant physician did not have a clue how much damage he had just done to that poor girl. Now, I do want to get off my soapbox finally and discuss the possibility of treatments in more detail. So that will have to be for next week's episode. Until then, be well and stay tuned next week for another episode of Healing Outside the Box.